Welcome, ladies and gentlemen. Thank you for choosing to hear about pregnancy and obstetric complications in pre-hospital trauma care. We'd like to thank the organising committee for asking us to present the topic and the work we've been doing to improve care in this vulnerable patient group. Before we begin, we'd just like to make our apologies for not being with you today. Unfortunately, clinical duties and jury service have kept us from presenting live to you. We were, however, very keen to take part in the conference and we've recorded our presentation. We hope that audio quality and AV difficulties don't spoil your experience. By way of introduction, my name's Emir Bataloglu. I'm a trauma and orthopaedic surgical registrar working at the University Hospital Birmingham. My major interests are in trauma and pre-hospital care. I'm a PHTLS instructor and also sit on the Faculty of Pre-Hospital Care Clinical Standards Committee.
And my name's Justin Chu. I'm an obstetrics and gynecology registrar. I'm currently out of programme doing a PhD at the moment at the Birmingham Women's Hospital. I have a great interest in trauma in the obstetric population, as I previously worked for Mr. Cox, who was the writer of MOE, and I also teach on a PROMPT course, which is an emergency obstetrics course.
As a matter of course, we've got no conflicts of interest to declare, and also we'd like to express that our opinions are our own viewpoints and do not reflect the position of the employing organisations or the organising committee. So to outline our presentation, we'll talk about the background of pregnancy and obstetric complications in pre-hospital trauma care, the physiological and anatomical changes in pregnancy which alter management, the challenges which occur in pre-hospital care, the influence on clinical management, in particular the ABCs. We'll touch a little bit about perimortem caesarean section, and then we'll talk about the limitations, controversies and potential areas for further research, and then we'll hopefully sum up with some take-home messages.
So just a quick few definitions and terminology from an obstetric point of view. We know that the potential for pregnancy exists in females aged between 10 to 55 years old, and therefore when you're seeing patients in the pre-hospital setting, this needs to be an important consideration when treating patients in this age range. The physiological and anatomical changes, which we'll cover later on in the presentation, become clinically significant from around 12 weeks and maximally so after 20 weeks. So, a bit of background about trauma in pregnancy. The literature that's available suggests that traumatic injury during pregnancy follows similar mechanisms to patients who are non-pregnant. So the main mechanisms of injury are road traffic accidents, falls and domestic violence. We find that blunt trauma is more common than penetrating trauma. The important obstetric risks here, the main ones are, firstly, placental abruption, which is usually when there's been abdominal trauma leading to premature separation of the placenta away from the uterine wall, and one must remember that this can happen even with minor injury, and also if there are extensive forces applied to the uterus, then rupture can occur.
The majority of the literature is based upon studies from North America and mostly from the United States. They cite trauma as a leading cause of maternal and fetal mortality and impacts 6 to 8% of pregnancy. 0.4% of these will require hospital admission, 0.1% will be involved in major trauma, and in terms of fetal outcomes, 3 to 7 fetal deaths per 100,000 live births will be following maternal trauma. From more extensive research, we find that in Africa, similar percentages are demonstrated, with South Africa having a 4% incidence of pregnancy and trauma. And in Nigeria, 12 out of every 1,000 pregnancies will sustain trauma during their pregnancy. So given the global perspective, we wanted to understand what the incidence for the United Kingdom was going to be. So we inquired from the Trauma Audit Research Registry data for 2009 to 2014 and found that there was a 1.1% rate of trauma in pregnant patients between the ages of 15 and 50. Now we found that in comparison to the non-pregnant female trauma patients, there was a higher incidence of road traffic accidents and penetrating trauma. We also found that there was a small decline in the maternal survival rate for pregnant patients. Now, given the very small numbers, this didn't reach statistical significance. But what was more startling, even given the low number of recordings, was the fetal survival rate at just 56%. So given the international perspective in comparison to the UK incidence rates that we were seeing, this made us think about whether what we were seeing was true or not. So when we take the expected rate, that of US trauma, given 250 per 100,000, in comparison to the UK trauma rate, so we're a much safer nation than our North American counterparts, and the US conception rate being just over 100 per 100,000, again in comparison to the UK of 80 per 100,000. When we combine all of those figures to extrapolate a pregnant trauma rate, we would expect to see about 70 per year. However, over the 5-year study, we only found 65 major trauma pregnant patients. And this makes us think whether there's a significant amount of underreporting which is going on, and whether this is a true incidence for the problem.
So now if we turn to the physiological and anatomical changes that occur in pregnancy, looking specifically at airway, there will be edema of pregnancy affecting the airway tissues, and there may well be some weight gain which can cause difficulties with airway management. Moving on to breathing, we know that respiratory function is altered by the enlarging uterus impacting upon the diaphragm, and the clinical impact is seen in the changes to pulmonary volumes and capacities, increasing minute ventilation, and this is what we call physiological hyperventilation. Minute ventilation increases primarily because of an increase in tidal volume as well as a decrease in functional residual capacity. These are in turn due to decline in expiratory reserve and residual volumes. The arterial partial pressure of oxygen remains unchanged, but there is a decrease in the partial pressure of carbon dioxide and compensatory decrease in plasma bicarbonate levels seen. As a result of a reduction in functional residual capacity, the pregnant trauma patient won't tolerate apnea, and supplemental oxygen is always indicated to avoid maternal and fetal hypoxia. Lastly, with regards to breathing, gastric physiology is affected. This reduces gut motility and also reduces esophageal sphincter tone, increasing the risk of aspiration. So turning now to the circulatory system, there is expansion of the plasma volume up to 45% over pre-pregnancy levels, resulting in a hypervolemic state. And this is often referred to as the physiological anemia of pregnancy. This is a protective factor for mother and fetus during periods of hemorrhage, which may be from trauma or obstetric. Therefore, an injured patient who is pregnant may lose up to 35% of circulating blood volume before exhibiting signs or symptoms of hypovolemic shock. There is a physiological maternal tachycardia, which is a result of cardiac adaptation to volume overload and elevated free thyroxine serum levels. The maternal heart rate may also increase by 10 to 15 beats per minute by around 12 weeks gestation, and increasing uterine size later on in pregnancy elevates the diaphragm, displacing the cardiac apex laterally. In combination with the increased circulating volume, the lower vascular resistance of the uterus and placenta, there is a great increase in cardiac output, approximately 25% greater than pre-pregnant levels. And this can be seen on this bar chart. Blood pressure also changes in pregnancy. Both the systolic and diastolic blood pressures decrease until 24 weeks gestation, with gradual recovery to pre-pregnancy levels by the latter stages of pregnancy. Uterine blood flow increases from approximately 50 mL per minute before pregnancy to 500 mL per minute at 40 weeks gestation. Another important change to the cardiovascular system during pregnancy is that the enlarging uterus compresses the abdominal vessels. This is present to a certain extent in all pregnant women if they're laid in the supine position. However, it may only clinically impact and cause supine hypotension in around 10% of pregnant women.
Now, this in a hypovolemic patient potentially is more likely and has a greater clinical imperative to prevent it occurring.
Methods for reducing caval compression are principally to tilt the patient greater than 15 degrees or to manually displace the uterus. In the pre-hospital setting, equipment or personnel obviously may be limited, and therefore this can be a challenge.
So when we consider the challenges in pre-hospital care for pregnant trauma patients, we break them down into two categories: those individual or those affecting on a case-by-case basis, and then global challenges which affect all patients and healthcare providers. So when considering some of the individual challenges to pre-hospital care, we think about the diagnostic challenges, so history taking, either from the patient themselves or collateral history from family members, examination findings, including examination of the abdomen, and then investigations which may aid us, including the potential for pre-hospital ultrasound to give us more information. In terms of the management, their impact upon airway, breathing, circulation, disability, as the changes in pregnancy which have been outlined can affect. Some of the interventions which we may need to perform, including endotracheal intubation, the need for vascular access, and the choice about resuscitation fluids, the use of TXA or tranexamic acid, and the use of pelvic binding. And then we're thinking about positioning of the patient. And then once we've done all of that, transporting the patient in the appropriate position to the appropriate destination, and that's without thinking about any extrication challenges which may be encountered. So global challenges include information relay, so dispatch details and the application of trauma triage tools, communication between individuals and potential modifications when dealing with a pregnant trauma patient, the services of receiving facilities and the major trauma centre networks, and then also thinking about training and continual education to provide the necessary skills and recognition for dealing with pregnant trauma patients.
So when considering airway clinical management in the pregnant patient, there is a need to consider airway security early. There's a heightened aspiration risk in pregnancy. During in-hospital intubations, this is a 1% risk, tenfold higher than other routine elective intubation in non-pregnant patients.
So when we consider pre-hospital intubation also carries a higher risk. And then when we're dealing with the pregnant trauma patient, we're bringing in a perfect storm or an increased risk of aspiration. Due to the edema of pregnancy, using a smaller endotracheal tube can improve first pass success. For practitioners without intubation skills, the use of second-generation supraglottic airway devices would be the next rung on the airway ladder. A note on surgical airways: the use of a vertical or longitudinal incision has been shown to have greater success rates than the traditional transverse incision, in particular when edema and adiposity may be higher in pregnancy, plus the use of a bougie is always advisable.
Just a small note regarding nasopharyngeal airways. Due to airway edema and the friability of tissues in pregnancy, there may be the potential for epistaxis during insertion. This is not a contraindication per se, but merely we would like to highlight safe placement techniques. Looking specifically now at the clinical management of breathing, supplemental oxygen should always be provided to all patients following trauma, as per BTS guidance. This applies especially to pregnant patients. Fears regarding the effect of high-flow oxygen concentrations on the fetus are emerging. However, oxygen should not be withheld to a mother who requires it. If after stabilisation or following minor injury, you can aim for titration of oxygen to maintain saturations at 94 to 98%, this would be ideal.
And then in the event of a need for chest decompression or the placement of thoracostomies, due to the anatomical effect of the uterus, we'd aim for the third or fourth intercostal space to avoid erroneous intra-abdominal placement.
In circulation, we have already mentioned about the physiological changes to blood pressure. This makes blood pressure an unreliable marker when used on its own to assess for shock.
Therefore, using it in combination with pulse rate, respiratory rate and conscious level are the main prehospital markers to use. Pregnant patients may have a greater hemorrhagic tolerance and can compensate longer until the point of circulatory collapse.
A focused examination of the uterus and the external genitalia is needed. A woody, hard uterus on palpation may well be a sign of placental abruption. Any bleeding from the external genitalia should be taken seriously, as the volume actually lost may well be greater than what is estimated.
Establishing vascular access, IV or IO, above the diaphragm aids resuscitation efforts by minimising the impact of uterine cable compression. IV access in the upper limbs is routine, but if difficult to site, then I suggest using the right proximal humerus as the primary site for IO access, which will also be helpful if you have to position the patient in a left lateral tilt.
Positioning to avoid uterine cable compression needs to be considered at all times, and the pregnant patient shouldn't be left in a supine position without manual uterine displacement. The physiological anemia of pregnancy is further diluted by the administration of crystalloid fluids and should only be titrated to preserve a palpable radial pulse. Early administration of blood products is what a bleeding pregnant trauma patient needs, and care should be directed as such. Tranexamic acid for trauma patients is well established, and currently the Woman trial is investigating its use for obstetric hemorrhage. Therefore, tranexamic acid should be given to pregnant trauma patients suspected to be bleeding, as per local protocols or guidelines.
The correct placement of pelvic binders over the greater trochanters for hemorrhage control should also be done for pregnant patients, and there is no contraindication to application.
Spinal injury in pregnancy is not seen to be at increased risk, and spinal precautions should be applied as per local protocols or guidelines without undue fear. If spinal immobilisation is required, then any wedging should be placed below the immobilisation device and supported along the whole length.
The unfortunate situation of maternal cardiac arrest is, however, rare, only occurring in 1 in 30,000 pregnancies. Effective CPR is critical. There are a number of prehospital challenges where patient positioning arises again and can compromise the effectiveness of CPR. Closed chest cardiac compressions generate approximately 30% of cardiac output when performed correctly. However, the levels of cardiac output decrease markedly if the patient is in a suboptimal position. Tilting, even with a firm wedge or support acting as a splintage for the chest, results in only about 80% of the compressive force applied when compared to the supine position, and this is even further reduced if attempted in a lateral position. Therefore, CPR in the supine position with manual uterine displacement is ideal if there is sufficient personnel available.
CPR should be continued for as long as deemed appropriate. As with any cardiac arrest situation, this can be very emotionally charged, and even more so when dealing with a pregnant patient. In the pregnant patient, however, there is another intervention which is known to impact on maternal survival, and this should be considered after 4 minutes of cardiac arrest. Following a maternal cardiac arrest, a perimortem caesarean section could be considered for maternal benefit only. There are two main factors why we would consider a perimortem caesarean section. The first is to empty the uterus, reducing the cardiac output to the uterus by around 1/3. Secondly, emptying the uterus also serves to relieve the deleterious effects of cable compression. Therefore, an increased likelihood of maternal survival is achieved from the improved vital circulatory volume following delivery of the baby. Performing a perimortem caesarean section is incredibly rare, and an obstetrician may only perform one in their entire career. But this would be the first action an obstetrician would perform for a mother in cardiac arrest if they were walking past. Even though it is rare, it is highly important to improve maternal survival, and all practitioners should be aware of it.
So we'll outline the procedure in an emergency or pre-hospital setting. So following maternal cardiac arrest, we'll begin CPR, ideally supine with manual uterine displacement. We want to exclude any life threats and prepare equipment and personnel.
Minimal equipment is actually required for a perimortem caesarean section. A scalpel and scissors is sufficient. A large midline laparotomy incision should be made. Division through the abdominal layers is next. Taking care not to injure the bowel or bladder, the uterus is then incised vertically over the upper segment anteriorly, and then the baby extracted. The cord should then be dual clamped and cut, and the placenta should be left within the womb cavity. If the perimortem caesarean section is successful, return of spontaneous circulation is most likely to occur immediately after emptying the uterus, and thereafter the abdomen should be packed for hemorrhage control.
CPR needs to be ongoing throughout, but extreme caution is needed not to injure practitioners. With or without perimortem caesarean section, maternal survival following cardiac arrest is poor. We understand it may not be within the scope of practice of all pre-hospital practitioners to perform a perimortem caesarean section. It wouldn't be considered mandatory, and pre-hospital practitioners wouldn't be criticised if they didn't feel comfortable to perform the procedure, but we wanted to stress its importance for maternal survival. The challenges continue when considering transportation of the injured pregnant patient. Tilting to the left can face the patient to the wall of a standard ambulance. Where to transport the patient is also an important consideration, as we want the right patient to the right place at the right time. The majority of major trauma centres have obstetric services available, however no children's MTCs do, and a number of trauma units may not have on-site obstetric services. The pregnancy status of female patients should be considered and clearly relayed to ensure appropriate receiving facilities are available. For handover purposes, the modification of an at-missed handover for pregnancy example is shown here. Age, including estimated gestational age, time of injury and mechanism as standard. Injury suspected, including potential obstetric complications. Any signs and symptoms, including obstetrical findings. Any treatments given, but also the need for obstetrics, paediatrics or neonatology to be on standby at the arriving hospital. Trauma triage tools should include pregnancy as a consideration for escalation of care. However, it's been shown in US literature that pregnancy is not a sole indicator for the need for major trauma activation.
Now, it might seem that we've left out a rather important part of the care of a pregnant patient that's involved in trauma, and this would be fetal care. However, we would really like to stress that the best fetal care that you can give is given by maternal resuscitation, and the mother and maternal survival is the priority in all situations. So this can be seen when we consider providing high flow oxygen following, for instance, minor injury. There are thoughts that high flow oxygen may have detrimental effects on the fetus. However, as mentioned before, we would issue high flow oxygen if there was maternal requirement and indication. The other point would be that following an injury to a pregnant patient, if there is no objective concern for the maternal trauma itself, a suitable obstetric review is still required, and a period of observation may be suggested in order to rule out an abruption occurring later on.
The evidence to support the best practice care for pregnant trauma patients is limited, thankfully due to the relative rarity of the condition, but greater understanding is required in order to further care. Understanding the true incidents, clarifying issues over oxygen, the necessary tilt, protocols and training for perimortem caesarean section are all really important. So in summary, we have a few take-home messages. 1% of female trauma patients between the ages of 10 and 55 are pregnant, as demonstrated by the UK Trauma Registry. Pregnancy physiology and anatomy Holter management. Early airway care and vascular access above the diaphragm are key. We try to avoid caval compression with the use of manual uterine displacement or left tilt. Effective CPR is critical following maternal cardiac arrest, and we must remember the issues surrounding perimortem caesarean section. Justin and I have been doing work on this topic as part of the Clinical Standards Committee consensus guidelines, and we hope to bring their publication to you soon. Unfortunately, we're not able to field any questions here, but feel free to contact me via email or Twitter, and I'll hopefully respond to you as soon as I can. Many thanks for listening to our talk.